Hello and welcome to Advanced Nursing. I'm reviewing the steps involved in assessing the eyes. The first thing we do is looking at visual acuity. Visual acuity is assessed by getting the patient to stand 20 centimeters away from the visual chart. The visual chart has different letters, and then you ask them to occlude one eye and then test the exposed eye and ask them to read the smallest letter possible they can read. So the visual acuity has two numbers. The top number stands for the distance between where the patient is standing and the chart, 20 centimeters. And then the number below indicates the distance that they were able to use to read the smallest number. So it means that 2020 is the best because at 20 centimeters, they can still read something that's the smallest number away from 20 centimeters. After assessing visual acuity, now we're going to inspect the eyelid. We'll be looking for color, swelling or edema, lesions or nodules, and we are going to be looking for the directions of the eyelids and also the adequate eye closure. So we'll ask the patient to open and close their eyes just to see the movement of the eyelids, and we're looking for symmetry as usual. We are ruling out any ptosis, which is eyelid drooping. We can have a sty, which is a painful and tender swelling at the inner part of the eyelid. And it can be caused by Streptococcus aureus, which is the bad guy causing so many different infections. But it can also be caused by like the obstruction of the tear gland. So many different things that can actually happen with that. You can have a chalazion, which is a non-tender noodle that is placed in the middle of the eyelid. So you are assessing to rule out these things, and overall asking the patient if they feel any discomfort or pain as they use or open and close their eyelids. And then after that, you're moving to palpation. So when you're palpating the eyelids, you are actually looking for lacrimal gland. It's right here, like laterally, just at the sides right here. The lacrimal gland, you are palpating that, just making sure that there's no swelling. And then you are also going around in the orbital area, just looking for any nodules or anything that is not in the healthy range. You're also looking at the lacrimal duct. Overall, you also want inspecting, you should have been looking for any sort of excessive tearing or dryness. And if you see excessive tearing, then you can do a nasolacrimal obstruction test. It's called nasolacrimal because the lacrimal gland drains into the lacrimal sac, and the lacrimal sac drains into the nasolacrimal duct. That's basically how the lacrimal gland produces the tears to protect the eye. So if they had extra tearing, you would be occluding the lacrimal duct, and you would press on it bilaterally. It's basically in the medial canthus right here. This is a canthus here, and then you would be looking for any leakage of fluid in the eye. It's just to rule out that it's not just excessive tearing just because of the season or whatever happened before the assessment, to make sure that the duct is actually healthy. All right, next we will now look at the conjunctiva. We have the pupibral conjunctiva. This is the pupibral conjunctiva is basically the inside of the eyelid. That's the pupibral conjunctiva. And then this is the bulbar conjunctiva. So it should be moist and pink. Just look for color. What color is it? It shouldn't be too red. It should actually be good pink. If it's red, there might be some sort of bleeding. The bulbar conjunctiva, it's easy. You can just pull back and you can take a look at the entire bulbar conjunctiva. You can see the color, that it's well vascularized, there's no bleeding or hematomas. But the palpebral conjunctiva, on the other hand, it's not easily everted or pulled on. So you can actually use a tongue depressor. You may need to invert the eyelid, especially if you are suspecting that there might be foreign bodies, especially for patients who say, it feels like something is in my eye, like literally. That could be a great opportunity to elevate the eyelid and take a look below the palpebral conjunctiva, especially it's probably the most hiding place in the eye, right? So if there could be anything, it might just be there. Do not press the tongue depressor on the eyeball, but put it on the upper eyelid, just below the eyebrows, and then you will just invert the, you see? Oh my god. Textbook versus reality. I think if the patient was perhaps in a spine position, this would actually be absolutely possible. This position is not ideal for that. You are looking for color again, but you're also looking for any foreign bodies, just to rule it out, especially if there is an indication or suspicion from your health history. After we assess conjunctiva, we're actually going to go ahead and assess the sclera. So you are looking for the sclera. When you're looking for the conjunctiva, ideally you were also looking at the sclera. The sclera should actually be clear. It will range population to population. For example, people with dark pigmentation like me, my sclera might not necessarily be pure white, and it's not pure white, and that's okay as long as it's bilaterally that way. If let's say my right sclera was one color and then left, that's a problem. But if it's bilaterally the same, ideally we are ruling out scleroicterus, which is jaundice, or yellowing, which could reflect like some liver problems. So it's going to show up differently than in different cultures. With people with dark pigmentation, scleroicterus will still look yellow, but it will be very dark yellow. So it's really important to also ask people, is this how your eyes always look, anything new and things like that. But just FYI, for people with dark pigmentation, you might not necessarily have it white, and that could still be healthy, given the health history. You take a look at the sclera very nicely, and after this we are going to take a look at the iris. So the iris, ideally you're just looking at the position of the iris itself. So the iris, as you can see, the eyelid should cover the iris slightly. But let's say someone was like this. If it was like this, that would be a problem. You shouldn't be able to see that much sclera inside at rest when someone is not using their eye. You know what I'm saying? If it's like this, your eyelid to pupil position should cover it like this. So you're just looking at the iris position, making sure that everything is fine. And then you will also look for corneal opacity. So corneal opacity is basically done to make sure that the cornea is not like blocked by anything. Like, for example, in different conditions it might not be clear, so you have the light shine through, and the light should light the entire eye. Light should light the entire eye. You just go one point to another, it's lighting the entire eye. if it doesn't light the entire eye, it just means that the opacity is not good. Obviously, make a referral to ophthalmologist after that. Now, next, we are going to assess pupils. The first thing we do with pupils is we're going to take a look at the pupil size. So I've got 1 to like 9 centimeters. So you can simply just put your pen light in front of the patient like this to see what is the size. And also we are looking for symmetry and certain condition like unisacoria. In unisacoria, pupils are going to actually have different diameters, and that means that there could be issues with either constriction or dilation of the pupil. So it's always good to start just by looking at the size in general, that they are actually equal. Then we move into assessing the pupillary reaction to light. So the first thing that we're going to do with reaction to light, we are going to look at the eyes obliquely, kind of like on the side. So we are looking for direct reaction and consensual reaction. So consensual reaction is basically the idea that, so let's do direct reaction. Direct reaction is if I put it here, this is my right eye is going to react by constricting. And then to the left, and I'm doing it obliquely, I'm not doing it directly, but it will still react. Now next, or you can even do it this way a little bit. You start here just to observe, and then you can go the typical one we do, but you are actually doing this while the lights are off. You turn the lights down so you can see properly. I know often people do this with the lights on, but I'm learning that it's actually best to do it with lights off. So you do it this way, you're just looking for the reaction, and then you go typical one that way and that way. Now the consensual reaction to light is the fact that I'm exposing light to this eye, but the other eye is also going to react. That's consensual. So we are looking for both consensual and direct reaction to light. Then we are going to assess our favorites. Extraocular eye movement. So to assess extraocular eye movement, you are doing the 6 cardinal or extraocular muscle movement, and ensuring that those muscles are working well, along with the cranial nerves in those areas. So you ask the patient to follow your finger, and you go extreme right, extreme up, extreme down, and then midline. And then you go extreme left, extreme up, and extreme down. You are confirming that all their muscles are working. When we go extreme right, we are assessing cranial nerve 6, which is abducens cranial nerve, and that's the nerve involved in abduction of the ocular muscles. If they say they can't follow your finger when you're going extreme right or left, and then with extreme up and extreme down, that is assessing cranial nerve 3, which is oculomotor nerve. If they have issues with the cranial nerve 3, then can follow up and down. It could be that maybe they're having optosis or drooping of the eyelid. Either way, if they can follow these movements, it's question mark, and we can confirm through consultations and referrals to ophthalmologists. And then finally, the midline is assessing cranial nerve 4, which is trochlear nerve. So if there's any issues with trochlear nerve, it could be that they're having eye weaknesses, and there is a condition called cranial nerve 4 palsy, when basically they're having issues with that nerve specifically. Then last but not least, we're going to assess for the conversion test. The conversion test basically is testing for the ability of the eye to see things closely and further away, so the nearby and further vision kind of thing. So you will take your finger and you will take it towards the patient's nose. In case if I'm the patient, I'm bringing towards myself this way, and usually the eye should be able to see things within 5 to 8 centimeters. So I'm bringing it towards myself right now, and I'm following it. So I will keep looking at it. I can still see it, and right now like I lose it as it comes. So like I see it, 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 and then I lose it. So that would be around 5 to 8 centimeters. Let's say if they lost it here, that would be a problem because it's still away from the vision and eyes should be able to see it. And then lastly, we are going to darken the room again. Anyway, the two most important times that you're gonna need to turn off the light during eye exam include when you're doing the pupillary reaction to light, and then finally when we are doing the thermoscope exam. We have the opportunity to take a look at the inner eye, and we're looking at the very specific structures, optic disc, making sure that the optic disc is slight yellow / orange with demarcated edges. If there is anything that looks different, then we would talk to someone else or make a referral to ophthalmologist. We are also looking at blood vessels, arteries and veins, and ruling out any pigmentation or bleeding. So to get started with a thermoscope exam, we will tune this to the best lighting. Remember, we turn the lights off, and we're gonna use right eye for the patient. So if I'm assessing the patient's right eye, I'm going to use the right eye. I will turn on the light here. The light is on right now. And then I will go, okay, assessing right eye. And the first thing that I'm looking at, I'll be looking for the light reflex. And the light reflex is really important. And once I see it, and I see that red light reflex, I'm going to follow it. I have to follow it and all the way close to the patient. It's going to be very close to the patient. Ideally, I'll have my thumb here, or my left hand, the hand that I'm not using to hold the equipment, right on the eyebrows, just to stabilize. And then I will take a good look, and ideally the patient is looking in one direction and just making them comfortable. And then I'll look at the structures, how the disc is looking, making sure that it's yellow / orange with demarcated edges, and looking at the blood vessels. The veins will be much bigger, and the arteries will be smaller, making sure that they are not like bulged or like they don't have any pigmentations. Just taking a good look. And then, if I have any suspicions, I'm not comfortable, I can always ask a colleague to help me look, or make a referral to ophthalmologist. So this is basically the basic steps for making sure you have a really good eye exam. This has been a good review for me. So, of course, this is in combination with patient's health history. Everything is going to be contextual, but this is the basic eye exam. Thank you, and I will see you in the next review.